Welcome, everyone. Please be mindful to keep yourselves muted during the event.
Welcome, everybody, to this very special event. It gives me tremendous pleasure to welcome you all and to thank you for joining us in our special grand rounds with Dr. Dave Shokshi, the Commissioner of the New York City Department of Health and Mental Hygiene. This is the last event in a series marking our 5th anniversary for the CUNY School of Public Health, consolidating and coming together as an independent school within CUNY. I thank Dr. Shokshi for agreeing to participate in our culminating event. And I also thank him for having his doors and his heart open to the Public School of Public Health in New York City. Although he has only assumed his position very recently, channels of communication between us have been open, and he has been more than gracious in responding to our needs and our questions, and has included us in ways that made us feel as true partners, true academic partners to his department. Dr. Shokshi is head of the preeminent public health department in the world. Previously, he served as chief population health officer at the New York City Health and Hospitals, where he built and grew an award-winning team dedicated to health system improvement, innovation, care models, and primary care transformation. He has taken care of patients as a primary care physician at Bellevue Hospital since 2014. Amongst his other previous roles, he served on the FEMA delegation to New York City after Hurricane Sandy, and he was the principal health advisor to the Secretary of Veteran Affairs. Dr. Shokshi also has written widely on public health and medicine, including the New England Journal of Medicine and the Lancet. Welcome, Dave, if you'll allow me to call you that, and please call me Ayman. This is a very special event and is attended by our faculty, our students, and guests from the community. And we welcome you today to CUNY, and we will focus our questions, obviously, on the topic of the day, COVID-19, the pandemic, and the vaccine. It is unbelievable. Every day there's a new turn of events in the newspapers. One is hardly able to catch up with the response to the vaccine, the various issues with various vaccines around the world, how governments are reacting, and how populations are reacting to them. So you have my wholehearted support and, need I say, sympathy in the midst of this very complex time. But let me ask you, the first question is, what is New York City doing to encourage the city's residents' participation in the COVID-19 vaccine rollout. Have these efforts been successful so far? Are you comfortable with the way things are going? And what more can we do to help you in any way we can?
Well, first, let me just say thank you so much, Ayman, for the warm introduction, for having me be a part of this special Grand Rounds. I certainly have a fond place in my heart for CUNY, but particularly for the School of Public Health, given how I know you blend the focus on equity with really trying to advance the frontiers of knowledge in public health, but also bringing a practitioner's lens to all of that work. So I'm truly grateful to have a bit of time to spend with all of you this afternoon. And yes, let me take up your question with respect to our vaccination campaign, which I don't think it's hyperbolic to say is a historic vaccination campaign for the city and for the world. We've, from the start, made it very clear that although the health department and the city government are at the vanguard of this, we really rely on this being not just an all of government effort, but really an all hands on deck effort for the entire city of New York. So I'm grateful that you phrased the question in the way that you did, which is our city's whole, every resident's participation in the vaccine rollout. There are, several different ways in which residents have been participating. Obviously, first and most directly, people are getting vaccinated, and that's actually a critical, part of ensuring that we reach our goals with the campaign. There are ways that we've enlisted New Yorkers to join our efforts as staff or as volunteers. So for example, I'm proud that we recently announced a Vaccine for All Corps, which will augment the staffing that we have at our vaccination sites and allow us to expand them even further across the city. We're one of the few places around the country that has already begun to do that. We also draw upon volunteers, particularly clinical volunteers, through the Medical Reserve Corps. And I can tell you, because I've done clinical shifts myself in our vaccine hubs, that they have been critically important for us to have the staffing that we need to turn vaccines into vaccinations. And one of the most important things, that I think about is, the idea that each person who gets vaccinated, we talk about the reproductive number of the virus. The number of people that someone who is infected with SARS-CoV-2 goes on to infect themselves. We have to think about that same concept when it comes to the idea of vaccination. Each person who is getting vaccinated has to share their story with other people, particularly people who may be on the fence about getting vaccinated for themselves. And if we make the reproductive number of vaccination, if you will, greater than the reproductive number of the virus, then that will be critically important for us to turn the corner on the pandemic. And finally, I'll just say, with respect to your question about how it's going, we are making good progress. We have set a goal of 5 million New Yorkers fully vaccinated by the end of June. This is a big, bold, a stretch goal for us to be able to accomplish it, given all of the complicated logistics and the supply constraints that we have. But we are on track as of now, to be able to meet that goal. We've administered over 3.5 million doses of the vaccine across New York City. And sometime today, actually, we'll cross the threshold of 1 million New Yorkers fully vaccinated, which is a remarkable milestone, as well as, a step in the right direction. With all of that said, it's not all rosy. This is, a challenging campaign and a rollout where we have to be very hard-nosed about areas where we need to continue to improve, which in my mind, I summarize under the rubric of age, race, and place. Age meaning ensuring that seniors, particularly have access to the vaccine, and that we prioritize our older New Yorkers to get vaccinated, because we know that age is the greatest risk factor for severe outcomes from COVID-19. But beyond that, thinking about race and ethnicity as well, for all of the reasons of health justice, which you have spoken about eloquently, but which is a fundamental part of our mission in redressing both historical inequities, as well as, unfortunately, the burden that has been borne by Black and Brown New Yorkers over the last 12 months during this pandemic. And those things, age and race, are also connected to the third point, which is place. One of the things that I feel most passionately about in public health is that we can't think about health in terms of diseases or in terms of interventions. We have to think about health in the ecosystems where people are actually living their lives. And so thinking about neighborhoods, as the units, the communities that we are responsible for in our efforts. And again, prioritizing those communities where we know there has been historical disinvestment, which has borne out very tragically during the pandemic. So overall, we are making progress, but we have to keep our eye on those areas where we need to continue to improve.
Thank you. It's a good segue to my next question, which is really focused on issues of race and ethnicity. And as you mentioned eloquently, there may be areas where we encounter perhaps resistance and in many cases historically justifiable and with important background. But in the interest of all, especially that certain communities have been really overwhelmed by the burden of this disease, and they are the ones that need our best attention and our best care in overcoming some of these challenges in accepting the vaccine. And so I'm going to ask you very specifically about what New York is doing to be able to help these communities reach good decisions for themselves and receive the vaccine in ways that protects them and their communities.
Yes, well, thank you for the question, and you're right. We have to unpack this a bit to really get at some of the root causes and the ways that we should be thinking about it. And it belies, sort of the simple explanations that may appear more superficially. So, for example, when we look around the country, I think we need to acknowledge the place where we actually see the greatest amount of vaccine reluctance or hesitancy is among white Republicans by a very large proportion, with respect to skepticism about the vaccine. And also, when we do think about skepticism in the context of communities of color, which, as you have pointed out, have had lower vaccination rates despite having borne more of the burden of COVID-19 illness, we have to understand why. One of the models that I like to use is the idea of asking the 5 whys. I have a toddler daughter, so she's actually very fond of this method as well. But I think we all have a lot to learn, from children in this respect. We can't just say, well, why are Black and Latino people getting vaccinated at lower rates? Well, maybe there is some skepticism, associated with that, and end the conversation there. We have to keep successively asking why. Why is there that skepticism, and tie it to the historical injustices that have been borne, again, disproportionately by those very same communities of color. There is both a history of racism in medicine and science, but we also can't lean too far back into the notion that this is something that is just reverberating from history into today. Even in the last few months, with respect to our COVID response, we have seen how racism has played out, with respect to whether or not people were able to access testing and able to access other resources that were critically important, to being able to take care of themselves and their loved ones during our COVID-19 response. One of the ways that I think is so tangible that I always think about, with respect to how we have to understand the whys, is think about someone or a family who hasn't had regular access to healthcare, and particularly preventive healthcare. The association that people have, and I know this from my own family, both here in the United States and in India, the association that people may have with a hospital or a clinic is always one where it is profoundly negative. It's a place where you heard your uncle went to get hospitalized and then passed away. It's a place where, someone who you had seen suffering at home for so long a period of time went, but wasn't able to get help or was treated poorly. And so those associations, very much matter with respect to how we think about the healthcare infrastructure is received and perceived by people whom are purportedly being served by that healthcare infrastructure. So all to say, even as we think about the historical echoes that do play out in people's decisions, we have to also understand that this is a very current phenomenon. I also want to unpack it a little bit more from the perspective of, we can't just think about it solely as a matter of psychology or hesitancy without having lowered all of the barriers that are our responsibility to have lowered. And that's where access is a precondition for even talking about something like hesitancy or skepticism. And with respect to access, we have to think about the ways in which we're citing our vaccination clinics, but also other elements of access, for immigrant populations, ensuring that there's adequate language access at those sites as well. Those are all critically important parts of making sure that we're meeting patients where they are and building confidence in a way that allows us to grapple with some of those deeper rooted issues.
Absolutely. I agree with you. We did a recent poll in New York, in Harlem, actually. And even between Central and East Harlem, we found differences, not across ethnicity and race, but just by potentially access to vaccination services. So in Central Harlem, the rate of vaccination amongst eligible groups above 65 were almost identical, be it amongst whites, blacks, Latinos, or Asians. They ranged at that moment, a month ago, between 25 and 28%. But then when we compared Central Harlem to East Harlem, then the rates were different, between 25 and 18%. So you're absolutely right. And it's very dangerous to kind of blame the victim and say, well, they are hesitant. Sometimes there are other factors, as you mentioned, which are ecological or environmental that play a role. The thing that's coming up a lot these days, and all of us are talking about it, is the issue of this new variant, to be honest with you. We're all kind of worried, and it interfaces with the vaccine in ways that, as we have read in the scientific literature and in the media, is somewhat confusing as to which vaccine is protective against what variant. So what can you tell us about the new COVID-19 variant that was recently detected in New York City, and how is the Department of Health and Mental Hygiene dealing with this new challenge, and how can we minimize the public's anxiety about the other foreign variants as we are encountering them in our great metropolis?
Yes, this is certainly something that is keeping me up at night, with respect to how the variants are playing out here in New York City. And let me just start by saying that I do think that the variants are a major contributor to the fact that our cases are not declining as we would hope, and to some extent as we would expect as the vaccination campaign continues to pick up pace. So this is what I think of as a tug of war between nature and New Yorkers, with the variants on the side of what nature is throwing at us, the indomitable spirit of us New Yorkers, but also these marvels of science in the vaccines on the other side of the equation, and we're really seeing it sort of becoming an even match right now between the two, which is why we are at a plateau when it comes to our case numbers as well as our hospitalizations due to COVID-19. And part of our job collectively is to do everything that we can to win that tug of war, to pull the curve down when it comes to cases and the severe outcomes. So let me say a little bit more about the variants. And you're absolutely right. It's easy to get lost in the alphabet soup of variants. For New York City, the ones that appear to be the most important at this point in time are the B.1.526 variant, which is the one that was first identified here in New York, as well as the B.1.1.7 variant, which was first identified in the United Kingdom. What we know about both of them is that there is evidence that that both are more transmissible. They spread more easily, and there is good data that the B.1.1.7 variant also causes more severe disease. It's more virulent. Thus far, it looks like the vaccines perform well against the B.1.1.7 variant, and we know that from both laboratory investigation as well as the more real-world experience in the United Kingdom, which has had quite a successful vaccination campaign. We know less about the B.1.526 variant, and we're very actively investigating this both in our own public health laboratory, but also with academic partners around the city to be able to better understand it. Because it has grown in proportion over the last few weeks, in fact, it's somewhere between 1/3 to 45% of all of the samples that are being sequenced right now. That is strong evidence that it is more infectious than other variants of the virus. But the other three key questions that I keep in mind: does it cause more severe disease? Is it more prone to reinfection among people who have had COVID-19 in the past? And then number three, does it reduce the effectiveness of vaccines? We're still waiting for the science to emerge, for us to be able to answer all of those questions. But we are, again, very actively looking at that, both in our own data as well as with our academic partners. At the end of the day, what I will say is that, despite the challenges that we're seeing with the variants, we also do know what works to curb the spread, whether it's the older version of the virus or these new variants. And it's what I call the safe six. You've heard us talk about the core four probably more times than you would even like, but we've updated that to the safe six, which is masking, distancing, washing your hands, staying home if you're feeling ill, getting tested, which remains very important even now, and then getting vaccinated when it's your turn.
Thank you. We'll make them 6 from now on, but I really think that this is always good advice. As far as we are experiencing from some of the polling and some of the data that is being gathered, is that the pandemic is not occurring in isolation, and that many other health issues are being identified as a consequence, perhaps, or associated with the socio-demographic challenges that are accompanying this pandemic, with isolation and with homelessness and with economic challenges. We're beginning to see certainly mental health challenges, issues related to the opioid usage. We're also beginning to see some of the chronic illnesses such as diabetes and obesity. All of these issues are conflagrated by the circumstances of the pandemic. And what is the department, as busy as you are, I can imagine that you cannot neglect these other co-occurring health issues, let alone issues such as hunger and homelessness. But what can you tell us about the activities within the department that are addressing these parallel epidemics?
Well, that's exactly right. And, that's the phrase that we use as well, the parallel pandemics. And I think it's important to frame it in that way because it shows that these are things that are linked to what's happening with COVID-19. They're linked in a few different ways. One is they're linked because of some of the underlying structural factors that lead to illness. whether it's illness due to an infectious disease like COVID-19 or illness due to opioid use disorder. The structural factors that lead to risk and exposure and poor outcomes are often in a common root. The other thing is that the virus itself and the ways in which it has changed our society has also led to challenges that exacerbate, those pre-existing problems that we've had with respect to public health. I just want to give a very vivid example, that I remember from my work. I was at Health and Hospitals, the public healthcare system, before I was at the health department. And that included at the peak of the surge back in March and April of last year. And I remember starting to notice this pattern in our data where we were looking at the trajectory of our ICU admissions for COVID-19. And as you can imagine, it was a steep upward trajectory toward the end of March and April of last year. But very interestingly, we looked at the non-COVID ICU admissions, and they were steeply declining at the same time. It created, what we called an X curve that we were seeing because people were not coming in for things as severe as strokes and heart attacks and kidney failure. And this was for the ICU. So just imagine what was happening in the world writ large with respect to all of the other, foregone problems with respect to medical care. Everything from diabetes, routine diabetes care to depression. All of that was unfortunately affected by COVID-19. And so, we've seen this in so many ways, and that's just the most sort of tangible example of the reverberating effects, that have taken on every single sphere of public health. So you ask, okay, so we can describe it, we can analyze it, but what are we doing about it as a public health department? And there are a few ways in which we have sought to address this, particularly with respect to opioid use disorder, food insecurity, which has been a major issue that we've seen worsened as well. Mental health related, of course, to this trauma and stress and grief that people have felt due to the events of the last 12 months. And we can't exclude racial injustice, structural racism as another parallel pandemic that underlies, so much of what has devastated New Yorkers. So we have updated our programs. That's one major way in which we've sought to address this. We started a methadone delivery service for people who were not able to travel to get their methadone to ensure that they were still able to be treated for it. We moved a number of our programs from our clinical work in the tuberculosis clinic to our early intervention work with very young children to a telehealth platform. And we did everything that we could to keep pace with those emerging parallel pandemics, particularly in the wake of the tragedy of George Floyd's murder and the appropriate outcry in its wake. Also ensuring that our race to justice efforts, which is an internally focused effort around racial justice, were also elevated to be able to meet the moment that we were in. So these are just some examples, but I will be the first to say that we have had to dedicate so many resources to our COVID-19 response, and we will have to do much more to address these parallel pandemics in the coming months.
So I'm, for the sake of time, I'm going to join my three last questions into one, but I know you can handle three questions in one. So I wanted to know what you've learned about the best strategies and approaches to bridge the public health and healthcare delivery as a result of what the city, as a result of combating the pandemic at the city level. I also wanted to know what you think about the future of healthcare and healthcare delivery in the post-COVID New York City, especially as regards to equitable health opportunities for all. And finally, I was really heartened to hear about the concept of neighborhood health corps, which came from your office, and wanted to see that as perhaps woven into the future of healthcare in New York, and your vision on that as an advocate for community health and primary health care. So I put them all in one. Now you tackle them whichever way you want.
Oh, thank you, Ayman. And yes, these are things that I feel so passionately about. You know, this is one of the animating ideas of my career, which is that public health and healthcare delivery are inherently intertwined. You know, they are part of a whole that any of us who care about health must embrace as that whole. You know, I'm a primary care doctor, so I saw this every single day that I was in the clinic, that there were certain things that I could do for my patients, but often the root causes of whether or not my patient was going to be ill or healthy extended far beyond the walls of my clinic. And that's the realm of public health. And so we have to think about the ways in which we can leverage, particularly the resources that exist in the healthcare sector for the aims and the structural tools that we have on the public health side of the coin. And, you know, this is something that I think we have to leverage in this moment, because it is not something that will remain in the realm of our, you know, academic or intellectual discussions about this. For the first time, this idea that public health and healthcare delivery are connected is something that we can explain to the layperson in a way that is very tangible and real, because they have seen how, for example, whether or not we were able to adequately physically distance was connected to whether or not someone ended up in the emergency room or the ICU. So we can trace that path of illness in a way that resonates with, you know, with everyday New Yorkers. And so we have to really make the most of this opportunity to make the investments and the changes that are required at this moment in time in what I hope will soon be the wake of the COVID-19 pandemic. To do so in a way that invests in those systems, but particularly the people. All of you, all of my staff here at the health department, but thinking much bigger and bolder in actually investing in a community-based public health workforce. This idea of the neighborhood health corps that is the physical manifestation of that bridge between public health and healthcare delivery. People who come from the neighborhoods that they are serving in a community health worker model, who can rise to the occasion during times of emergency, as we saw we needed around testing and contact tracing last year, and as we see are needed right now with our vaccination efforts. But in between those emergencies can also respond to the slower moving disasters of chronic disease, including mental illness and substance use disorders. So all to say, you know, this is something where we have such a unique moment because of the attention, the spotlight that is on public health right now. And we have to really make the most of this opportunity. I think about it in the historical parallel. You know, we are in a once in a lifetime, you know, once in a century pandemic. And we have to avoid the fate of what was true after the 1918 influenza pandemic, which you're probably aware, Ayman, is noted by historians as the forgotten pandemic, in part because not enough actually changed or shifted in society after that devastating event. And I think it's part of our charge, part of our responsibility to ensure that the same thing doesn't happen for public health in the aftermath of COVID-19.
Thank you very much, Dave. I will encourage the audience to put their questions in the chat column here. And in the meantime, I will say that today is a special day for us, Dave, because the School of Public Health at CUNY received the Harrison Spencer Prize for the top school with community service amongst the 178 schools and programs in the country. We just received it at the annual meeting of the Association of Schools and Programs in Public Health. So we beseech you not to forget about our public health graduates. They are very special students at our school, and to think of them also as part of your army in changing health in communities. So of course, community health workers have a role to play, but hopefully the young generation of community-oriented public health students will also have a role to play. I'm going to open the chat to be able to read what questions, and I see, well, Mary Woolley was just congratulating us on winning the prize. Thank you, Mary. And then
I echo those congratulations. That is very, very well deserved.
Thank you so much. I'm looking for a question here from Anne, who says, how do you think the various political events like mayoral elections are impacting the efforts at countering the pandemic? Very political questions, Anne. Okay, so tell us what you think within the realm of diplomacy.
Well, speaking of things that are inherently intertwined, it's not just healthcare delivery and public health, but it is politics and public health as well. And certainly, politics are things that change the way that we think about our response, and they set up the structures and policies, that we have to work within. What I keep in mind is that our elected officials are just that. They are elected by the people, to make decisions and to serve New Yorkers. And I think there's actually a very healthy and robust conversation happening in the mayoral race right now about the role of public health. And I think it's a shining example of what I was trying to also lift up, which is this is such a unique moment for us where health is at the center of so much. People understand health and public health in a way that wasn't true 1 year ago and certainly wasn't true a decade ago. And so it's incumbent upon us to inform that conversation, to take advantage of this once in a generation opportunity for us to take the things that we believe in so strongly, that we have so much conviction about, and ensure that our elected leaders are informed by it when they're thinking about how to take on mental health in the wake of the trauma and the stress that people have experienced, or to give them the ways to discuss and operationalize how we can dismantle racism as part of our response to public health. So I'm overall heartened by what I've seen thus far. I think this mayoral administration has invested quite a bit in health, and so I think there are some programs and initiatives that I'm very hopeful will continue forward as well.
Thank you, Dave. And we've not heard public health mentioned so actively and aggressively as we are. Pedro, one of our faculty, is asking about whether you're involved with the Department of Corrections and how you are making sure that people who are incarcerated are part of your vaccine rollout. Would you like to tell us something about that?
Yes, and thank you, Pedro, for the very important question. It's something that I have thought about a lot because we know that among the different layers of risk exposure, being in a congregate setting, which a prison or a jail represents, is one of the most, one of the riskiest exposures that one can have. So it's particularly important to ensure that people who are incarcerated have access to vaccination as well. And the short answer is yes. The Correctional Health Service falls under the banner of health and hospitals, our partner, the public health care system. We've ensured that they are supplied with vaccine and assisted in their vaccination efforts. And we are seeing, people who are incarcerated starting to get vaccinated over the last several weeks. And our plan is to ensure that that ramps up as quickly as is possible.
Thank you. Adrian Delgado was asking a question that suddenly disappeared. Let me see if I can go back to it. Anyway, it'll come next. Another question from Zaka German. Yesterday, Governor Cuomo sent an email asking New York State citizens to enroll to become a New York State citizen public health leader. Is that an initiative you are partnering in?
The short answer is I'm aware of that initiative. I think there are a lot of shared goals with the notion of a neighborhood health corps that I mentioned. It's a little bit more targeted toward lay people, who want to get some public health training, sort of in the model of mental health first aid, if you're aware of that. And so it is a state-run initiative rather than a city-run initiative, but lots of shared values and goals. And I think they're partnering with Cornell, if I recall correctly. So the city is involved in some way, but not through the health department.
Thank you. And then going back to Adrian's question, Dr. Shokshi, the US government has financed a very large fraction of vaccine research. Vaccines are now being sold with a great profit by private pharmaceuticals. Do you agree it is important to have the suspension of intellectual property rights relative to vaccines so that enough doses are produced and distributed the world over? Of course, we're all very concerned about middle and low income countries and how they're going to be treated in that regard. So what is your point of view on that?
Yes, well, I hope another one of the lasting lessons of this pandemic is how interconnected our fates are, not just within a city like New York, not even within the United States as a large country, but across the entire world. What happens in Wuhan affects us in New York City. What happens in Guinea and the Democratic Republic of Congo affects us in New York City. And so if it weren't enough for us to be caring and compassionate about our fellow human beings around the world, solely by virtue of the fact that diseases and illness know no borders, we should turn our attention at least for that reason. And so with respect to the specific question, yes, this is an area where in a previous life, I did quite a bit of work in understanding how intellectual property was connected to access to medicines. And I do think that it is too often a barrier with respect to access to medicines and particularly access to vaccines right now. So I do support, the creative use of techniques to relax patents, to have governments in a public health emergency ensure that intellectual property is not a barrier to get therapeutics and vaccines to the places that will most benefit from it.
Thank you, Dave. We did issue a letter of conscience only recently, and I was one of the signatories with my fellow deans here in New York about that very same topic. We couldn't be more delighted that you agreed to participate with us today in this culminating event of our 5th anniversary. The relationship between the Public School of Public Health in New York City and the Department of Health and Mental Hygiene is integral to our identity, our mission, and our future. Your kindness and your wisdom really impressed all of us and the participants that were with us today. And we hope that you find the School of Public Health a destination where you will visit frequently and a partner with whom you will seek collaboration whenever our skills are valuable to you. Welcome to the first encounter here at the school and hopefully the first of many to come. We're very grateful to you. Thank you, Dave.
Well, thank you. It's really my honor and my pleasure. And Ayman, thank you for having me. Thank you for the stimulating conversation. I look forward to our continued partnership. And congratulations once again. I think it's a particular prize to wear with pride, given how much you genuinely care about your community focus. So it is well-deserved and motivation to keep doing more and better in this particularly important time.
Thank you again, and thank you for all the participants, and happy 5th anniversary.